Hello, good evening, everyone. If you can hear me, please can you drop a comment on the comment section so I know that I can be heard. If you can hear me, please drop a comment in the comment section so I know that you can be heard. Please do not type your model number, do not type your name. All right, just drop a comment on the comment section. All right, thank you very much, Sonia Obebo. Okay, so I remember taking us ARVs. ARVs are just a short form of antiretroviral drugs, and I took some time to explain the different classes of ARVs, and I told us that because of the nature of our syllabus this semester, we may not be having enough time to go through all the case studies. We may not be having enough time to go through all the case studies that that we are supposed to have. Okay, so hence the reason for this class. So I understand the difficulty with everyone in trying to join this this class. It's also stressful for me, as you can see. I'm supposed to be at home resting, but I just want to ensure that everything I need to do, I do them as regards your syllabus this semester, so that you can be well grounded and well prepared. Also note that this this class is recorded, so anytime you want to refer to any information in this slide, you can come back and use the same link with which you joined to play whatever information you need. So I'm going to be very fast because we have about 10 case studies to analyze. That's going to broaden our knowledge on ARVs. So the first case study we're going to start from here. Please kindly ignore this case study 6. It's supposed to be case study 1. I I do not have enough time to edit them. So Mr. Kenneth, 38 years old, newly diagnosed with HIV. CD4 count is 150 cells per millimeter cube rather. Complaints frequent cough, weight loss, night sweats. So the patient is asking you as a nurse and is saying, what does this CD4 number mean? Is it serious? So this is like a good way to introduce. I remember when explaining the in the class, I didn't mention anything about CD4 cells. You understand? So the reason why it is very good for us to do case studies, because it's going to bring out new question, new perspective to the topic, and when you have something like that, it's going to be easy for you to have a broader knowledge. Okay, so what does she? That's what the patient is asking. What does the CD4 does it for me? Is it serious? So the questions under the case study is number one: what does CD4 count mean? And what is normal? What is the normal CD4? What does his CD4 count of 150 tell you? So the 150 cells per millimeter cube. Then what complication is he at risk for? Okay, because of that CD4 number, is at risk with for many things. All right, number four, how will ARV help his CD4? All right, how will ARV help his CD4? What is ARV in this case? ARV, like I mentioned in the beginning of this class, is a short form for antiretroviral drugs. All right. So we are going to be number five. How often should CD4 counts be checked? So we are going to go through this and then see how we can answer. So first of all, the first question is, what are CD4? So CD4, they are white blood cells that fight infection. You see that cell I drew on the board in class. That I said the HIV infect enters the cell. The type of cell that they actually infect are CD4 cells. They feast on them, they eat them. Those are the classification of the cells that they eat, that they enter. All right, they feast on those kinds of cells. Okay, so that's CD4, and then CD4 cells are part of our immune system. They help us fight immune. All right, and HIV attacks them. Okay, so it means that when you are checking CD4, when you're checking for HIV infection, the level it has gone, you will now check the volume of the CD4 a patient has. You understand? So if HIV virus is infecting CD4 cells and destroying them. So when you want to know the severity of people's HIV status, you will count the CD4. How many is remaining? If it's few that is remaining, knows that this patient has had HIV for a long time. because it has destroyed a lot. If it's plenty that is remaining, you know that this patient's HIV is just barely recent, or probably the immune system is strong. You understand? So the normal CD4 count is 500 to 1,500 cells per millimeter cube. All right, normal CD4 is 500 to 1,500. So please note that. Then, what is the other question? Okay, what does the CD4 of 150 means? 150 now, if the range is 500 to 1.5, it means 150 means very low. Okay, so means these patients have very low cells, very low immune system that can fight off infection. All right, so this HIV is quite advanced. All right, so and means that this person is very very prone to having diseases and different kinds of attack. Alright, the only reason why this person's CD4 is low is because the HIV has been in the body for years, destroying the CD4 cells. So um, the immune system is very weak. That's what it implies. So what are the complications? That's question 3. That is at risk for. So is at risk of having what they call opportunistic infection. You know what opportunistic infection is? Our body helps us to fight bacteria, viruses, and the rest. And then when we are unable to fight those, we we eventually end up having what they call infections all around. Because you see, as you are breathing in, there's a chance of you being infected of whatever infection that is flying around. But because of these CD4 cells, we're able to fight them off. But when HIV starts destroying CD4, it means that we then now become unable to fight off the normal infections we usually fight off. All right, so that becomes a major problem for for everyone that is infected with HIV. So one of the side effects, one of the opportunity infection is tuberculosis, pneumonia, candidiasis, and several issues, and several other diseases. Okay, it's not exhaustive. So how we the fourth question say how we ARV help its CD4 count. So ARV will stop the HIV cell from multiplying. Remember I taught you fusion. It will stop it from entering. It will stop it from converting reverse transcriptase stop from converting RNA to DNA. Then to stop it from integrating. Then to stop it from maturing. So those are how ARV will work. So if ARV can stop it from entering that CD4 cell, the CD4 cell will keep multiplying. All right. So then the last question: how often should CD4 counts be done? So usually CD4 counts are usually done every 3 6 months, every 3 months rather. So when you start your ARV, you check. When you start the antiretroviral drug, you check for 3 months. After you continue taking your drug, you check again for another 3 months, and that is how CD4 cells are checked. So far, so if I'm talking and you have any question, I will appreciate if you can just drop it on the comment section. I will read it out, and then we can all uh, respond to it together. So the next case study that we are going to be doing is case study 7. Sorry, it's supposed to be number 2, but just ignore the numbering. So Mrs. Jane Okeke, I just hope this name does not rhyme with anybody's relative. These are just names I made up my own. So please, next time I'll be using abbreviation so that it can be much more um what do you call it? It will be more private. All right. So she started ARVs antiretroviral drugs today: tenofovir, lamivudine, and dolutegravir. Now, class, this combination you're seeing here, tenofovir, lamivudine, and dolutegravir, are the first line treatment for HIV. All right, I remember giving you assignments on how to examples of each classes. So what I would advise you for you to do is check, as where this class is going on or much later, check the classes that tenofovir belong to, lamivudine belong to, and dolutegravir belongs to. Okay, so this patient asks, why do I need 3 different drugs and how do they work? So I remember telling you, I don't know if I said it in class, that in treating HIV, you don't just take one medication. You don't take one medication because of how smart the virus is. I think I mentioned that. I say you use combination of medication. Sometimes 2 drugs from one class and then 1 drug from a different class. So you're trying to do what? You're trying to attack the virus from different point of view so that to reduce its replication and increase the chances of survival. All right. So the question now is, Explain how HIV multiplies in the body. I've explained that for you already in class. How does each drug class work to stop HIV? The question three: What are the three drugs needed instead of, okay, why are three drugs needed instead of one? What happens if it takes only one or two drugs? What is the main ARV drug classes used in Nigeria? So I think because of time, we are going to skip explain how HIV multiplies in the body. Sorry for that sound. That is a knockout. So I don't know if you can hear it, but ignore, please. The area where I stay is not really that sophisticated. All right. So how does it really multiply? They convert RNA to DNA, and DNA they enters the human cell and multiplies, and then they assemble together, and they release, and then they mature, and blah 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 blah. That is how they multiply. That's the question one. So how each drug class work? So how each drug class work? I've explained. I also explained how each drug class work with the way the HIV cell, the HIV virus multiplies. You understand? So I told you there's fusion inhibitor, there's reverse transcriptase inhibitor, there's nucleoside and non-nucleoside. Remember what I drew in the class? Two different ends. Okay. Then there's integrase inhibitor preventing the viral DNA from entering into the human DNA. All right, there's protease inhibitor, which is assembly inhibitor. Then there's a maturation inhibitor. All right, then there's also another question that says, why three drugs are needed? Because you have to attack the HIV virus from more than one point. Okay, you have to attack the HIV virus from more than one point, and then it gives you more chance of creating an effective treatment, and also to prevent drug resistance. Okay, to prevent drug resistance, and then it will also lead to a faster result. You know, the aim is to prevent the virus from destroying CD4 cells. I know your CD4 cells are responsible for your basic immunity. So if you are destroying those viruses enough, you see CD4 cells become more, and they are able to what? They are able to um, prevent further infection from other diseases. Okay, what happens if it takes only one or two drugs? Okay, what happens if you take only one or two drugs? The virus is smart. I told you that virus is smart. I think I mentioned it in one of the classes. So what it do is that one drug or two drugs will only prevent the virus for a few days. And after a while, the virus learns how to overcome that, because of course it's just only in one place you are stopping it. But if you are stopping it in more than one point, like 2 or 3 points, you realize that it eventually eradicates the virus from the body. You understand? So is um multiple points is usually better than administering the drug in one particular point. All right. Then what is the last question? What are the main ARVs? What are the main ARV drug classes used in Nigeria? So that's basically um that's basically part of the assignment I gave to us, listing the examples in the drug class. But let me just straight. So first line treatment basically, we have the NROTIs, the nucleoside reverse transcriptase inhibitors. Those are very, very important. Remember, I told you that reverse transcriptase enzyme is one of the most important enzymes the virus has. If you can stop it, you make the virus useless. So NROTIs are usually the major drugs that we have. So example, we have lamivudine, zidovudine, abacavir, tenofovir. All right. So it's part of the assignment, so there's no point for me to list that on the screen for you to see. Then there is also the NNROTIs, which are still used, but they are usually used rarely, especially in some, except in some resistance cases. Okay. Then there is the integrase inhibitors. Okay, integrase inhibitors. We have the dolutegravir, all right, which is one of the best options because of its mild side effects. It's okay. So that is that for that particular question. I'm not seeing any question on the chat box. If I see any, I'll respond. So let's go to the next case study. This case study tests us on post-exposure prophylaxis. So now we have Nurse Blessing, age 26. I don't know if there's any blessing in this class, but it's fine. Occupation nurse, Incident: needle stick injury 3 hours ago while taking blood from HIV patients. Worried, will I get HIV? What should I do? So the question is, what is PEP and and when should it be used? So is there anybody who can let us know what the full meaning of PEP is? Who can let us know what PEP is? Just type it in full for me on the comment section so that before we continue, let me be sure that you're following. I'm waiting. PEP, post-exposure prophylaxis. All right. Post-exposure prophylaxis. Okay, somebody asked me a question. It says, do they have side effects, each of these retroviral drugs? Yes, they do have side effects. They do have side effects. We'll get to the side effect. I don't know if I have any case study on side effect, but we'll get there. If they are, we'll analyze them together. And then I also saw a question. Does HIV, let me look for that question. I think I missed it. It says, does HIV affect any other white blood cell? Does HIV affect any other white blood cell? Okay, I've seen it. This is from Nature Lover. Please, can you please edit your name to be your name in class at least, or your first name in class, whatever. Because it's Nature Lover, I don't know what to call you right now. So, does ARV affect any other white blood cell? Yes, it does. It affects granulocytes and some other class of drug, but those are not our particular those are not of interest right now, because what we are trying to do is that, HIV definitely reduces the immune system, and that immune system, what it does is, when the immune system is compromised, many other diseases come in, and that is the problem with HIV. You understand? So that's that for that. So please, if you ask a question and I miss your question, what you can do is repeat the question again. Okay. I'll, as I'm talking, sometimes I can forget to look at the comment section and then address the question. All right. So what is PEP? Thank you for mentioning. Somebody said, or a lot of you have said that PEP is post-exposure prophylaxis. So usually given in an emergency to prevent HIV infection, and is given after a possible HIV exposure. All right. So I must start within 72 hours. All right. It's not 100%, but it's effective. That is, why do I say it's not 100%? The quicker you give it, I'm going to be teaching you contraceptives. You understand what I mean by it's not 100%? Now, contraceptives will work within 0 to 42 hours, 72 hours rather. So if a person takes a contraceptive, some emergency contraceptives within that 0, 6, 5, 7 hours, the higher the chance of preventing pregnancy is, the faster you take those medications. All right. If you delay taking your PP, it will also reduce the effectiveness. You understand? So when there's a needle prick, you use it. When there's a sharp instrument injury, you use it. When there's blood splash to eyes, nose, mouth, you understand, you use it. When there's a contact of blood to a broken skin, you use it. You understand? So that's the reason why um um that's the reason why, as a nurse, you wear gloves to cover your hands because of your fingers, the orifices in your fingers. You wear mask to cover your mouth, nose, and the rest. So, what PEP does, that I told you, that PEP eventually they help to prevent the conversion of that RNA to DNA. You understand? So usually PEPs are usually 80%, above 80% effective. So that's that. Then how soon should you start PEP? So the sooner the better. Ideally, usually within 2 hours, 2 to 4 hours has the best chances to get it started with. Okay. If there's any issue, any problem, you cannot get it within 2 hours, ensure you get it within 24 hours. You understand? All right, it can still be helpful within 72 hours, but I'm just trying to ensure you understand that the medication is taken early enough to prevent HIV infection. You understand? So, what does the next question says? Next question says, um, what medicines are used for PP and how long? All right. PP definitely will involve the first line treatment of HIV. I told us that we have a first line treatment of HIV, which TLD, what I explained, tenofovir, lamivudine, and dolutegravir. Tenofovir, lamivudine, and dolutegravir. Now, that is TLD. Just note that as a very important abbreviation in your management of HIV, because if I'm going to be asking you a question in the exam, I'm going to be asking you a question that relates to that first line. Okay, so that first line is also usually what forms the PEP. All right, and because it's a combination, in order to make it easy for for compliance among patients, what they did was that they made that combination into pack of one. That is, a patient can be swallowing a tablet today and is swallowing a combination of those three drugs. I don't know if you understand. So a patient can take that can be a patient can be taking just one tablet, all right, but it is a combination of those three drugs. You understand? Just like though you have Panadol extra, where you have Panadol, paracetamol, and the caffeine. Then what other drug again? You have diclofenac, and paracetamol. Many of them like that. But it's just one tablet you are taking. However, it's a combination medications. You understand? So what are the side effects of PEP? So generally, nausea, headache, tiredness, dizziness, diarrhea. Okay. I think I remember telling us in class. Um, I remember telling us in class that there is a first symptom of HIV. Who can remember what I said as one of the major symptoms, first symptoms of HIV? Who can remember what I said? I mentioned about two major symptoms. Who can tell me? Who can say that? Or just type it in the comment section. Let me see. Weight loss, God bless you. VQ3T, night sweats and weight loss. Princess Best and nocturnal sweating choice, Chase. Okay, that is fine. So it seems you're following. So if you remember one of our case studies, you see, with one of those patients, they had those symptoms. I did not say vomiting. No, I didn't say vomiting. Were you in my class? We say vomiting. Okay, it's fine. But please, that is that for that. Then what to do? The follow up to do is in the first week you just check for any side effect of the patient. Then you ensure that the patient is following up taking the drug properly. You understand? Then in the last week of the PEP, where the patient is taking the last week, what you just have to do is to ensure the patient do an HIV test. Okay, and that test should eventually show negative. All right, so that is that for that. We'll go straight to our next case study. I'm trying to wrap up very fast. So case study number 9, which is supposed to be number 4. Sorry for the miscounting. So first line and second line treatment. These questions are going to test our knowledge on first line and second line treatment. Because what is first line treatment? First line treatment is the best treatment with the least side effects. Please pay attention to this point. The best treatment with the least side effects. It doesn't mean that any other combination will not work. No. We are trying to let you know that in first line treatment, say, oh, this is the first line treatment for ulcer, this is first line treatment for malaria, this is first line treatment for HIV. It means that whenever a patient comes down with this disease, this is the first drug we'll give until this first drug has failed before we try another drug. Why did they select this first set of drugs? It's because they select them based on their effectiveness, they select them based on their tolerability, they select them based on their side effects. So this first line, if it works for the patient, fine and good, patient is good, the side effects are mild, and then this patient is doing fine. But if first line fails, second line are usually much more harsh, but with more side effects. You understand, more problem, more and reduced tolerability. You start seeing different kinds of symptoms in these patients. Okay, so that is that for that. So in first line, in testing knowledge on first and second line, we have Mr. Paul Adebayo for 5 years on first line therapy. Remember I said TLG, I mean TLD. But now this time we are using TLE. I will explain why. For 3 years, he has been using this drug for 3 years. So the recent viral load test shows 5,000 copies per mil. Is quite low, so the level is undetected. So resistance shows resistance to efavirenz and lamivudine. All right, so doctor says we need to switch to second line. Ask, what does this mean? Did I do something wrong? That's what the patient asks. You understand? Okay. So the question is, what is the first line versus second line treatment of HIV? Then question two said, why did the first line fail for him? Then question three said, what medicines are used in the second line? Then question four says, how is the second line different from first line? About question five says, why should you teach him about second line treatment? So I've already explained what first and second line means. So like I mentioned in the first question we are addressing what is first line and second line. First line combination is usually like given to patients that are just new, like they just newly diagnosed them. Okay, it's most effective, few side effects, easy to take, and usually they are cheaper. You understand? So the two kinds of first line that we have is tenofovir, lamivudine, and efavirenz. Now, efavirenz is old. So dolutegravir is a much more recent drug. That is the reason why they replaced efavirenz with dolutegravir. All right. So the first line treatment will work for basically 90% of patients. All right, very tolerated and is once daily. You know, when you're taking the drug once daily, you know that it is quite easy for you to comply, and it's very difficult for you to find a treatment issues. Okay, with with medication that you're taking one day. However, for the second line treatment, so the second line treatment is usually combined when or usually used when the first line treatment fail. They use different classes. This one they will sorry, I said it right. They will include other classes. I taught you other class apart from remember that first line treatment is integrase inhibitor and NRTIs. Okay. So in this second line, they are going to look for other classes like fusion inhibitor, protease inhibitor, and the rest. And usually in the second line, you have more drugs to take, and sometimes expensive, and sometimes more side effects. Okay, so there is also a third line, and there's also a fourth line, but we don't go into that. Those are for really pharmacology students, medical doctors, and pharmacists to study. So basically, you just stop in first line treatment, which is cool. So why did the first line fail? You should know that. If I ask you a question in an exam like this, there are many reasons why first line treatment will fail. Compliance issue, adherence issue. I don't know if you understand. Drug resistance. All right. I remember I told you in class that people who are infected with a particular strain of HIV virus can eventually still be infected with another strain of the same virus. So all those people say, I've gotten the virus, let me start sleeping around. It's it's it is still counterproductive because there's still a chance for them to get another strain. And that is where usually sometimes leads to resistance. You understand? So sometimes there's also poor absorption of the drug can lead to resistance. Then interaction of the drug with some other medicines that the patient is taking can lead to resistance. All right. Then the patient asks the question, did I do something wrong? Okay. Ask what does it mean? Did I do something wrong? Possibly the patient is not doing something. Possibly the patient was adhering to the drug. So there's also the issue of drug interaction with maybe the patient went to visit the auntie and say, we heard that you have HIV, oh," and you say yes. So what are you taking for your HIV? Start saying, I'm not taking anything. Oh, okay, please add this in agbo and you take the herbal medicine and it goes there, reduce the absorption. I taught you all absorption. I taught you absorption last semester. That will now affect the absorption of the HIV medicine you are taking. So therefore, the amount of drug that's supposed to be in the bloodstream reduces, and the HIV start growing resistance from there. You understand? So that is that. So what you just have to do in is counseling this patient and ensuring the patient understand the impact of what second line treatment are. Question three: what medicines are used in second line treatment? Okay, I think this one is beyond your grade, but basically I'll just mention it beyond your coursework rather. So in second line treatment, we are adding a protease inhibitor. So what we are doing, we are taking instead of the integrase inhibitor, we are removing the integrase inhibitor and adding one protease inhibitor. So in the first line treatment, we are using two NRTIs and one integrase inhibitor. In second line, we are using two NRTIs and one protease inhibitor. And pay attention, the two NRTIs. I assume that when I say NRTIs in this class, we are not confused. NRTI is nucleotide nucleoside reverse transcriptase inhibitor, nucleoside reverse transcriptase inhibitors, NRTIs. So when I'm saying two NRTIs, it means that there are two. You will take two examples of drugs in as an NRTI and one example of drug as an integrase inhibitor. Okay. So now in the second line treatment that I'm still repeating that we are going to be using two NRTIs. We are going to be using another two different NRTIs that was used in the first line. Okay. So lamivudine, tenofovir, and dolutegravir. Lamivudine and tenofovir that are examples of NRTIs. When we are in the second line, we are going to be looking for two opposite or two different NRTIs that were used initially for the patient in the first line. So that's why I say it's quite complex, but just leave all of that. All right. So question 4 says, how is the second line different from the first line? So class, first line, I gave you the advantage of first line. It is cheap, easy to take, once daily, lower side effects. So it definitely means that there will be some complications taking second line. So first line, easy to take, cheap. Second line would not be easy to take. So probably it's more expensive. Not probably, it is. It is more expensive. Then it requires multiple dosing. You see that first line where you take one daily. In second line, the patient will be taking every 12 hourly or sometimes 6 hourly. And you see patient taking more than one drug per day, or up to like 6 to 5 drugs per day. I know those things are discouraging and they will reduce compliance. You understand? So what should you teach the patient about second line therapy? Which is the last question there. It says, what should you teach the patient? What I will just explain here is emphasize compliance, emphasize the patient declare the kinds of herbs they take. You understand? Then the patient must take them with food because it helps the reabsorption. All right. So that is that for that. I'm not seeing any question. I hope so. It's all right. So the next case study class. So this case study we are going to be discussing side effects and management. So we have one Mrs. Mamaka also. I really hope nobody's name is this. These names here was fine. 33 years on ARVs, Dovudine based for 6 months. Complaint, I'm always tired, can't do my home housework. My nails is turning dark. It is normal. So lab result shows hemoglobin 8 gram per DL. The normal range for women is 12 to 16. So it means that this person is already lacking something. All right, when you see. Now, when I'm going to be giving you any question in exam that requires you to, if I'm giving you any question in exam that requires you to have to emphasize or to check the parameters of any patient, I'm going to be giving you the normal range. You know, so for example, this lab result that shows. All right, nature lover, I've seen your question. In case a woman who is pregnant, she is HIV positive, how can she prevent her child from getting pregnant? I think we are going to get there. We're going to get there. I think I have one case study on pregnancy in HIV or HIV in pregnancy or whatever. So somebody also said, is second line more effective? No, second line is not more effective. The most effective are first line. However, second line are unique. Why do I say unique? They act in different way than the first line. You understand? So the reason why first line is there as first line because they are potent, very effective, they have fewer side effects, and they are cheap, easy to take, plus many other advantages. Second line is harsher, stronger, and can lead to severe side effects. I don't know if you understand. So that is the challenge with second line treatment. It's not really the fact that they are more effective. All right. So it's just because this HIV virus has learned how to deal with the first line drugs. Let us try something else. And this something else we're not trying now is also working, but now comes with severe side effects. That is the difference between first line and second line. So please, if I were you, I'll pay attention to that information because it's looking at something that I will be tempted to ask whenever I need to ask you any question at all. So now let's quickly go to the case study number 5, which is written 10 here. So please ignore. So I was telling you about lab results. If I'm going to give you any lab results in the class or in the exam, If I give you lab, for example, PCV, I don't expect you to cram the normal range. I'm going to tell you the PCV of the patient. I'm also going to give you the normal range. So it is from the normal range you're going to deduce what to do. Because eventually, when you start practicing as a nurse, when you are looking at any lab results, you are going to also see the normal range by the side of it. Even doctors, they still use the reference materials before they can make informed judgment. All right. So, so that's that. So now, number, okay, am I going to now? All right. So now let's go to the questions. What is the side effect causing heart tiredness? What is the side effect causing heart tiredness? What causes the dark nails? What causes the dark nails? Somebody's asking if HIV drug is not free. Ha. I don't know. I'm a pharmacology lecturer. I'm not a business person. No. You can sometimes, yes, I think it's free. You can go to any hospital, tertiary institution, and then find out. All right, but I don't know if it's still free because I know it was free before. If you have a response to that, if you know if it's still free, you can drop it on the comment section. It's not like we suspect that you are taking the drug, but just help Ogene Teviga. Please help Ogene Teviga know if HIV drug is free. I don't know why he or she needs it, but just help. If you have an information, just say share. So now, number 3, how should anemia from this drug be managed? What other unique side effects do different ARVs have? How do you help patients to cope? So we'll just breeze through that very well. So side effect of zidovudine, also known as AZC, is that zidovudine actually affects the bone marrow. All right, and bone marrow is where your red blood cells are produced. A large part of your red blood cells are produced in the bone marrow. So if a drug acts or is absorbed in the bone marrow, definitely whatever function that bone marrow does will either be reduced or increased. But in this case, it is reduced. All right, so that's why you see that patient is having reduction in blood, in red blood cell hemoglobin. Hemoglobin is 8 and the average is 12 to 15. All right, low blood anemia, and why she's tired. Red blood cells carry oxygen. So if the red blood cells are fewer, it means that oxygen transport is reduced and then leads to fatigue, weakness, and tiredness. And this one is usually a known side effect for zidovudine. It happens to between 10 to 30% of patients. So if 100 patients are taking zidovudine, about 10 to 30 of them will come down with this severe side effect of tiredness. All right. All right. So what causes the dark nails? So that does not mean in class now you start looking out for your classmates that have dark nails. No, that would be a very bad thing to do. All right. It's known as nail pigmentation. That terminology is known as nail pigmentation, and it comes from people who take zidovudine. Okay. So what happens is that it affects some of the nails or all of them, and then it turns them dark, just like the way your nails are a little bit light now. It turns them dark as your knuckles and your knee. All right, and then this is as a result of a melanin deposition in the nails. It's not any problem. It's not harmful. It's just one of the side effects of zidovudine, and it's not dangerous. Just explain to your patient that if it happens, there's nothing to fear. So number 3, how should anemia from zidovudine be managed? So you will give iron supplementation. How anemia is managed now, especially those in pregnancy. You give iron supplementation and the rest. Then sometimes you reduce the dose of zidovudine. Some other time you just quickly switch away from zidovudine altogether. Then if it becomes so worse, you give blood transfusion. All right. So side effects: zidovudine will cause anemia, nail pigmentation. So if I am asking a question in the objective and I say a patient presents you and complain of nail pigmentation, what medication is this? What likely medication is this patient going to be on? Definitely zidovudine. All right. So then there's some other ones that have other unique side effects. Tenofovir, for example, kidney problems. Sometimes patients come down with kidney problems, bone marrow problems. Then there's efavirenz. Efavirenz is known as a drug that can cause you to dream. That can cause you to dream vivid dreams, nightmares. You start having serious and severe nightmares. It's efavirenz. Efavirenz is a drug that can cause that. Then it can also cause depression. Efavirenz can also cause rash. You understand? And then verapine can also cause rash and liver toxicity. So all of these drugs, they have their unique side effects. And then how do you help patients cope with these side effects? Now, basically, class, to help patients cope with side effects is that is by giving them information beforehand. You see, like I mentioned, what separates you from the average nurse out there is the ability for you to give a proper nursing consideration to your patients taking drugs. If you can tell the patients, madam, as you're taking this drug, your nail is going to be turning black. There's a chance for your nail to be turning black after about 3 or 4 weeks after taking this drug. You see, when it eventually happens, the patient is not scared. All right, the patient is not scared, and have the patient have the, what do you call it, the assurance of the healthcare provider. So if you do not tell the patient that information, and then it happens, the patient becomes scared, even if you are explaining tomorrow, it will not be as assuring as when you had earlier stated that information. Okay, then choice is asking, since the blood is reduced due to drug, so will a blood tonic be added to medication? Of course, I said hematinics and iron supplementation will also work for zidovudine. Remember, this side effect is zidovudine. They also remember efavirenz causes CNS side effect, which is anxiety, sweating, um, vivid dreams, and nightmares. So um, this is case study number 6, which is label number 1 here. So Mrs. Joy will be 28 years. I don't know why all my examples are women. Do I have any to women? I don't think I have any to women. Tracy, sir, please, does HIV replication work same as HPV? No, I will talk on HPV later. I think it's part of your syllabus. That's Tracy Jones. All right. So, diagnosis, newly diagnosed with HIV, CD4 count 400. And please, you can remember the range of CD4 I mentioned is a normal range. Please, let's follow. Can remember, who can remind me? What is the range of CD4 that I mentioned is a normal range? I'm waiting for comments. 500 to 1,500. God bless you. Osayande Jennifer. Blessing work boy. All right. Thank you very much. So it means that you're following. Now, it's not like this information, you can't get it on Google or anywhere. Now, I do not want you to do that. Why is that? Because any information you copy online or you get online, it will not stick, or it may not stick, except you're a good crammer. I don't know if you know. So I need you to listen. I need you to understand. I need you to picture. If you have any problem, go over this video and watch it again. Because when you learn it, when you hear it, people say it, when you discuss it, so you can also form discussion group. When you hear people say, do you understand? It will stick faster than what you see on text. Okay, some of you can remember what your parents told you 3 or 4 years ago, but you cannot just remember the book you opened yesterday. That is how hearing works, and that's how learning works. So now let's go back to this case study fast because of time. Newly diagnosed HIV, and this is a CD4 count 400. It means this person is highly, or it's not really, is beyond or below the range of 500. So the patient is taking tenofovir, lamivudine, and dolutegravir 1 tablet daily. So obviously this person is on first line treatment of HIV. Okay, patients ask, nurse, do I have to take this medicine every day? I'm worried about side effects. So what are the 3 drugs? Questions. What are the 3 drugs in TLD and their drug classes? Why must she take all 3 drugs together? What important points should you teach Ms. Sobi about ARV? What side effects should she watch for? When should she return for follow-up? So we are going to treat all of that. The 3 drugs are tenofovir, lamivudine, dolutegravir. They are all drug class for HIV. The reason for the combination, they attack HIV at different places. I told us the reason why we combine drugs. Then what to teach the patient, teach them adherence. Then one another important point is that they should never skip dose. They should never skip their doses. I don't know if you understand. Advise the patient not to ever skip doses. Okay. Advise the patient not to ever skip doses, because when they skip doses, it's going to be a problem. Then advise the patient to take their drug at the same time every day. Let them set an alarm. Of course, you know why. The reason why is because of absorption, metabolism, excretion. The availability of the drug in the blood is very necessary. So if you are taking the drug by 7 a.m., ensure you continue taking it by 7 a.m. Don't skip it. So you see most persons that are treating HIV, they usually put their drug in their bags. If you are going to be taking it by 8 a.m. or 8 p.m., they have to be taking it every 8 p.m. They have alarm for it. Sometimes they will employ or pay somebody to call them to remind them, because that's how important it is. Because once resistance forms from that first line, you will be tired of taking the drug. Patients will be tired of taking the drug because you will now be taking it 3 to 2 times daily, and that is worse with severe side effects. You understand? So you have to ensure you teach the patient the importance of all of that. So what side effects should you watch out for? Remember, this patient is not on zidovudine, so therefore there's no pigmentation. All right, so there's dizziness, there's tiredness, there's nausea. So and sometimes headache. Then sometimes please pay attention. Sometimes this first line treatment can cause acute kidney disease, which is urine is dark, skin rash, there is difficulty breathing, and there is jaundice. All right, so whenever all of those things occur, you know that there is a issue with the kidney or the liver, and it has to be treated appropriately. So I'm seeing a question, sir. Does this drug NNROTI? I can't see your complete question there, nature lover. Please let us type it in full so that I can see it. So case study number 7, Mr. John is a all right. I think we've done this. Case study number 7 is actually working on side effects. So let's skip that. Let's keep that. All right. This one is talking about opportunistic infection. This case study number 8. So Miss Grace Okoro, 30 years on ARV, problem diagnosed with tuberculosis using birth control pills. So this patient is using any of the hormonal drugs to prevent childbearing. So can she take tuberculosis drugs and ARVs together? Question 1. This is going to test our knowledge on drug interaction. What changes are needed for her ARV regimen? Number 3. What about her birth control pills? What should you monitor during treatment? How long will she take both treatments? Now, it is very important that when you're advising patients all of this information, you have a principle. You have what they call a guided knowledge. All right. So first of all, yes, you can take them together. Now, one other thing you should know is that no matter the condition this patient is treating, ensure that they did not stop their HIV drug. So if the patient is treating cancer and HIV, ensure they don't stop their HIV drug, because it is worse when the HIV become resistant. So you see that first thing you're going to tell them, do not stop HIV treatment for any reason. All right. Then you should take the tuberculosis drug and the HIV drug together. So what changes are needed for HIV regimen? Now, this is drug-drug interaction, which is basically a detailed pharmacology question. But I will just say it's not necessary for you at this level. I think I'm going to teach you tuberculosis in your second semester in pharmacology 3. I'll teach you tuberculosis, so you should just know this. One of the drugs for tuberculosis is rifampicin. Rifampicin actually interacts with many drugs, so and it will reduce the absorption. So rifampicin can also reduce absorption of some drugs that you take for HIV. All right. So that is that. Then also, rifampicin will definitely also affect the birth control that the patient is using. So of course, the patient should now look for other means. When I'm teaching you contraceptive, you understand when there is going to be a drug interaction with any of the oral drug you use, the patient has to switch to barrier method, because barrier method are usually they protect too, especially when the hormonal methods fail. What should you monitor during treatment? All right, you check for side effects, you check for weight loss, you check for kidney function and liver function, and then you also check for CD4 counts. All right. So that is that for that. So let's quickly go to case study number 9. We're almost there. Thank you very much for your Thank you very much for your patience. Now, yes, nature lover. NROT and NROTI both prevent RNA virus conversion to DNA. Yes, yes, but at different points. I drew it in class. I drew it in class. Nature lover, I drew it in class. Were you in class? Oh, which class is this now? Okay, but I remember drawing it in class. So, choice, but won't the other drug alter the effectiveness of the HIV drug? Yes, it will, but you have to continue taking it. Now, usually, what they will do is that before you treat tuberculosis sometimes or any other condition with HIV, they will first of all try to boost this person's CD4 count, take a lot of HIV, anti-HIV, and antiretrovirals, so that the CD4 count will increase. Because with higher CD4 count, you are able to survive all of these diseases better and faster and easier. All right, Choice, I've answered your question. I think that should work. So, number 9, poor adherence. Let's leave that. I already told you the importance of patients of taking their drugs for HIV. If you miss the drug, I've repeated it too much. That's why I'll skip that case study. So, this case study is going to talk about pregnancy and HIV. For the person who works on pregnancy, of pregnancy. Then there is dope boss wife. What kind of funny names are this? Sir, how long will HIV medication last for before the patient gets used to the drugs? Are you losing its potency on the patient? There is no long, if the patient is committed, if the patient is consistent, compliant, and adhering very well, the HIV virus not be used to it because you are killing it, you are destroying it. What will only happen is that this person's CD4 count will continue increasing, the HIV viral load will continue reducing up to undetected level, and person will be living HIV free life. Not like person does not have HIV, but is living HIV free life because the HIV virus is undetected. All right. So only time whenever there's the HIV virus get used to drugs, if the person is skipping drugs. If you miss drug as much as 2, I think is in that case study I skipped. All right. Is in the case study I skipped. The case study I skipped that says question 1, what has happened before what has happened because of the missed doses? How do you counsel about adherence? What solution can help the patient? I think I mentioned it there, that when you miss up to 3 to 4 doses per week, hmm, 3 to 4 doses per week, you are giving the virus chance of resisting. You understand? Okay. Double wise, how long does that mean that the medication doses will be increased? No, you don't increase the dose. Even if you skip a drug, you change the class, you change the drug altogether. Like if a resistance has been created, you don't increase the dose, you change the class altogether. You understand? So increasing the dose is just like wasting your time. You understand? The virus has developed a resistance to it. So just change the class to something that it does not have resistance to. So let us quickly go. The last one. So Mrs. Blessing Adamo, 25 years, 10 weeks pregnant, newly diagnosed HIV, 500 cells, viral load 30,000 copies. Will my baby get HIV? I am so scared. So this patient is telling you that they are scared for their baby. Question 1. What is the risk? Question 1. What is the risk to a baby without treatment? When should ARV be started? So without treatment, the baby has a chance of 20 to 45% of getting HIV virus. So it's 50-50 eventually. All right. Can happen during pregnancy, during delivery, or breastfeeding. All right. So when you use a proper treatment, the chance is less than 2%. All right. So the 98% of babies are around HIV negative if they are following treatment plan. All right. When to start treatment is immediately. At that time, you start treatment. The earlier you start treatment, the better. All right. The medicine that is used for them is the same thing, the same first line, so lamivudine and dolutegravir. Now, to see how safe those three is, they are using it for patients with pregnancy. You understand? All right. So, how does ARV protect the baby? When the patient mother takes the drug consistently, it eventually reduces the viral load, and then it reduces the chance for the virus to be transmitted to the baby. When the viral load increases, that's when it increases the chance of transmission from the mothers to the baby. All right. So before delivery, they will also check the viral load before um before the mother gives birth. That's at 36 weeks or 38 weeks. When does delivery take place again? 36 or 38. They'll check if it's higher, if the viral load is higher than 1,000 copies, um, they will use a cesarean section. All right. She can breastfeed. She'll continue to take care of ARVs anyway at TFD. Then you don't mix formula and breastfeeding together. You just give only the baby breast milk, or you give only formula, any of them. Then the baby also will be given a syrup called nevirapine syrup to help boost the baby's immune system, and also, sorry, not immune system, to help fight and destroy any trace of the virus that is in the baby's body at all. It has a syrup, okay, and that is that for this class. This is exactly 1 hour, and I promise that we are not going to stay more than 1 hour. So thank you very much for your time. But before we go, okay, there are plenty of questions here. Let me handle the questions. But before we go, I have to take attendance, so please don't run away. Ensure that if you're in this class, so you stay for attendance. Can a patient take HIV drug and another drug at once, or one after the other? Any other treatment the patient is taking alongside the patient's HIV drug. Maybe the patient is treating malaria, patient is treating typhoid. Yes, you can take them together. It has no issue, except when in some cases like that tuberculosis drug, rifampicin. Rifampicin is an antibiotics, so the doctor can advise on what to do as at that time. All right, that is from Promzy. Promzy, I hope you get that question. There's another question from Nature Lover. This Nature Lover, I really want to know you. I told you to change your name yet. You have not done that. After using the drug to that level undetected, will the person after using the drug to that level of undetection, will the person still be able to transmit HIV? No. When a drug is undetected, it eventually becomes untransmitted until when it becomes detected again. All right. Um, if a patient, if a HIV patient have ulcer, this is Jeffrey. Have ulcer, can they take their HIV meds along their ulcer meds? Yes. Uti Jeffrey Okoko. Then this is from Dope, Dope Boss Wife. Sorry to go off the line. An HIV pregnant mom during delivery was counseled to breastfeed her baby for 6 months without infant formula. Now I have seen nipples bleed over time during breastfeeding, as in if. Okay, yes. You see, the essence of taking um, HIV ARV during pregnancy is to reduce the viral load. Right now, reducing viral load and during delivery, there's always a mixture between the mother's blood and the baby's blood. And when that mixture happens, it can lead to infection of HIV. So if you notice that last question we did, if the viral load is high, greater than 1,000, to do CS, because that limits the exchange of blood between the mother and the baby. So eventually, when there is a blood, there's a chance of reinfection of the child, and that can also be considered. However, remember I told you that usually when babies are born, they give them nevirapine to reduce the viral load. So if it's within that period, this child is taking nevirapine. Remember how PAP also works, and could also cover for it. But I don't know if it's beyond that period, then it may not cover for it. And will a 6 month child have teeth to bite the mother's nipple? That's a question for the women to answer, not me. Then Omon Z's Jelly, sir, how can a CKD manage how can a CKD how can a CKD manage HIV since excretion process will be difficult and dialysis may wash it over? Oh, this is a very clever question. Osa Senaga, God bless you for this question. Now, chronic kidney disease. Most drugs are excreted to the kidney. All right. So usually when patients are having end organ damage, remember I told you in first semester, second semester, 100 level, that when patients have organ disease, the doses will be affected. So if patient have liver disease, for example, they will reduce the dose of the drug because it will be problem with the drug, with the patient metabolizing that drug. So if a patient is also having kidney disease, the dose of the tenofovir, lamivudine, and dolutegravir that is given will also be reduced. I don't know if you understand. So it's pari passu. So will be reduced. That it will also account for the kidney disease that this patient has. There are ways to calculate all of that. The baby is not properly latching on the mother's nipple. Okay, I've answered that question on the boss wipe. Can someone come back to first line treatment after moving to second line treatment? Like the HIV also forgets the first transfer. No, you can't do that. Um, During the phase of breastfeeding, the mother is told to continue breastfeeding. What about consuming bloodied milk? I think I've addressed this question, but answer if a mother can also, a baby between 6 months can have it is to bite the mother, because that is what causes bleeding now, right? That causes bleeding when the child beats the mother's nipple or something. When the child become undetected in an NIVA, can the person stop taking the medication? No, please don't take it. Now, we've seen cases where people think that they've cured from HIV, they testify in church, but which is very good. Okay. Now, for you to know if you are really cured from HIV, there are tests to do. It's not just doing that viral load test. There are major tests to do that will check if you are no longer having HIV. All right. So that's that for that. Thank you very much, everyone, for your questions, for your interaction. I really do appreciate, and I really do appreciate your time. Sorry for every um sorry for every inconvenience this class has caused, but I know it's for the greater good. It's costing me inconvenience too. And then I'm going to drop a link right now. This link is a Google form. Fill it, submit it. This link is going to be available between now. Nigeria is going to be playing a match between 8 p.m. and 9 p.m. or in the next 1 hour 30 minutes. So in order for me to capture those that only attended this meeting, I'm going to leave this link open for the next 15 minutes. So I will drop a Google form here. I'll drop a Google form here. Um, what we just have to do is you fill the form and you fill the form and submit it. Now in this Google form, there is going to be a place to collect your email, your phone number. Please do that, and your MAT number. I want to beg you, please, when you write your MAT number, don't write 320319. Write it in full. If it's ND2 slash, write it in full. Okay, that's how I know. And your full name. Okay, write that in full. And please, it's going to be asking some questions about what I taught today. Whether you fill the question or get the question, it is not necessary. Please don't copy online. Don't get the answer online. In fact, people who get 20, 19 over 20, I pick them out. In fact, I will come to class and ask you. If you get any question, if you get, especially some of the hard questions I'm going to ask, if you get it, I will come to class and ask you. I will come with my laptop. I will go through the people who get some questions. And if I notice that you cannot really answer the question you got on the form, I'm going to penalize you. I'll go to asterisk your name and then mark you absent. Yeah, so the point is, it's better you get 0, because this whole form, the whole question here is 1 mark. So once I can see your mark number and your name on that form, you're getting 1 mark. So the number of classes I hold this semester, it's going to be 1 mark each for each of the classes, and it's going to count cumulatively. So please do not. Okay, some of you don't have matric number. Please, if you don't have matric number, just put your phone number, put your full name there. I can trace you with your full name. It's not a problem. All right. So the Google form is here. I have attached the Google form there. The Google form is pinned to. The Google form is pinned. It's on the screen. Check your screen. You'll see it now. I think I'm supposed to pin it. How do I pin this? So try to walk. Try to get on it and start. I think I started. I don't know how to pin it. So I don't know. How do I do this internet something, but it's fine. Just fill the Google form. If you're having problem filling it, let me know. So let's fill the form. All right. God bless you, and see you guys in my next class. Hopefully after your students week, or next week Saturday or Sunday again. All right. Bye for now, and take care. Okay, the site is not working at your end. Why? Why is it not working at your end? Why? What is the problem? Probably it's network. So since it's network, I'll give you time. I'll give extra time to fill it. The site is not working. So try the second one. All right, take care and ensure to complete the form. And if it's not still working, please one of you tell your class rep or assistant class rep to chat me now in the next few seconds that I put it there, because I'm going to turn off this form from receiving comments exactly 45 minutes when Nigeria matches when Nigeria on the first half. All right, so listen to this and get that information so that I can in the next 45 minutes you should have completed filling the form. Bye.